Good afternoon, everyone. Respected teachers, my seniors, and my colleagues. Today we will be discussing on area management devices. I am Dr. Manjay Maharjan, medical officer from Pathan Hospital, Department of GP and EM. So basically, today we will be discussing about the anatomy of airway briefly and identification of artificial airway devices, how to identify the devices, parts of the devices, and which device to choose. And we will be comparing the devices, so which will be better against which. And at the end, we will briefly discuss about the algorithm for airway management. So briefly describing about the anatomy of the airway. As you all know, we have nasopharynx, oropharynx, hypopharynx, and laryngopharynx. The main identification that we should distinguish is that the common pathway between passage of food and passage of air is in hypopharynx, and committed airway or definitive airway starts from laryngopharynx, and which separates into trachea and esophagus. So the main objective or goal should be securing this larynx. As we can see, this is an epiglottis, and it prevents it acts as a valve to prevent fallback of food into the windpipe. So it is necessary, and it is our ultimate goal to place a device such that it does not enter into the trachea, and the trachea remains open. As we can see, tongue is a big muscle. It can also fall back in the posterior pharynx and cause obstruction. So we also have devices that can prevent fallback of tongue and keep this hypopharynx open. So if we see our mouth from starting, first we can see the tongue. And as we gradually progress, we can see base of the tongue, we have vallecula, and from here, food passes through the side of this epiglottis. So this is the epiglottis, and if we see a laryngoscopic view, we can see epiglottis, and here are the vocal cords. So this is the basic anatomy. And now indications of airway devices. So why do we need to put airway devices? So the first and foremost is to secure airway in any patient. Second, to supply oxygen, and for general anesthesia. Fourth is for resuscitation during cardiopulmonary resuscitation. And in fifth, in ICU setting, if we have to ventilate the patient, we will be requiring airway devices. So before talking about airway devices, there are simple maneuvers to open the airway, and as we all know, they are head tilt and chin lift maneuver and jaw thrust maneuver. These are both are the simple maneuvers to prevent fallback of tongue and open the oropharynx, hypopharynx, as we have seen that tongue can push into the posterior pharyngeal wall and cause obstruction. So head tilt and chin lift maneuver and jaw thrust maneuver. Between these maneuvers, we should not do head tilt and chin lift maneuvers in a patient with C-spine or cervical spine injury, as it requires the movement of cervical spine. So to differentiate, we have to differentiate and identify a patient of C-spine injury and proceed towards maneuvering whichever is better. So for routine airway management, what are the equipments? So first is an oxygen source, and second and mostly used is a bag and mask ventilation. So we need to have the capacity of bag and mask ventilation. Third is laryngoscopes and several endotracheal tubes. The main discussion today we are doing is not about endotracheal tubes, but other devices that are comparable to endotracheal tubes and has much comparable benefits to endotracheal tube. So we'll be discussing on that later. Other is suction, oximeter, stethoscope, and we need to have monitors and IVSS. So first one we'll be talking about is oropharyngeal airway or Gudel's airway. So this is a very simple instrument that can be used to prevent fallback of tongue. So the basic parts are, it has our phalange, it has a bite lock, it has a body, and this curved side is the tongue side. So it will prevent the tongue from falling back. So first is in any airway devices, it may be simple or advanced. First is sizing. Sizing is very important in any airway devices. So how we will be choosing a Gudel's area of correct size is that we'll be measuring from the angle of mouth to the angle of mandible. So whichever fits the best will be the choice of size of Gudel's area. And the placement is also very simple, and the mostly used maneuver is we have to slide the Gudel's area with face pointing towards the nose or upwards, and we'll be simply rotating it 180 degrees, so it will push the tongue towards the side and prevent its fallback. The major disadvantages are we cannot use this device in a conscious patient, as it is a rigid device and will not be tolerated, and also it may cause laryngospasm. Other simple airway device is a naropharyngeal airway device. This is made of a pliable tube, so it is much more flexible than Gudel's airway, and you can also be used in a conscious patient. Uh, uh, the sizing, we have to choose the size of this naropharyngeal airway from tip of the nares to earlobe. So from tip of the nose conares to tip of earlobe, whichever size fits best should be choose. And the placement of this device is done such that it has to be lubricated first using xylocaine jelly, and with the bevel tip, it has a bevel tip. So this bevel tip should be facing towards the nasal septum, and it should be gently inserted through nares with twisting movement. The disadvantage of this device is that it has a high risk of epistaxis, as major vessels will be running through this nose, septum of the nose. So it has a risk of epistaxis, and it is less desirable in patients of thrombocytopenia and coagulation disorder, as well as it has to be used in with caution in a patient of basilar skull fracture, as it may pierce the cribriform plate and reach cranial valve in such patients. So next, commonly used device is a bag and mask ventilation. It is always the first step in management in most situations, and it also provides adequate pre-oxygenation for rapid sequence intubation. However, it has a high risk of aspiration and is yeah, designed to provide around 75% of oxygen. Sorry. So this is artificial manual AMBU bag. So this has a reservoir bag which can be connected in this side, and it has an oxygen outlet. So this is a face mask, and one of the very important part in artificial manual breathing unit AMBU bag is this face mask, and position of this face mask, size of this face mask. So this is a re-inflatable bag, and this will be providing our tidal volume. So this is there are ways of securing a mask in bag and mask ventilation. The commonly used technique is C and E technique, which is a one-hand technique where the C forms around the rim, and we place our other three fingers at the angle of mandible and base of mandible. However, this provides less security, and in case we are resuscitation with more than one personnel, we can use thumbs down technique, which is mechanically more advantageous, as we can provide better seal in this. So both hands will be used, and thumbs will be placed in the mask, and we can secure it with the other fingers in the base of the mandible. So this is our bag and mask ventilation. So the major discussion topic today will be supraglottic airway devices and use of supraglottic airway devices. Supraglottic airway devices are used in both spontaneously and ventilated endotracheal airway. intubation in both bag and max ventilation and endotracheal intubation have failed when endotracheal intubation has failed. And among all the supraglottic airway devices, none offers protection from aspiration pneumonitis uh, as provided by endotracheal tube. So we'll be discussing on various supraglottic airway devices as well. And common disadvantage of all supraglottic airway devices are sore throat and injuries to lingual, hypoglossal, and recurrent laryngeal nerve has been reported. So we can see the various types of laryngeal mask airways. Dr. Brain invented this classic laryngeal mask area in 1980s, and it has been modified a lot of times, and depending on the modification, it has several advantages and different uses. So supraglottic airway devices coming to now, today there are basically three generations of supraglottic airway devices. First generation are simple airway tubes, which consist of classic LMA, flexible LMA, which we will be discussing in further slides. Second generation. So as we increase the generation, the advantages is that there are more passages for maneuver and draining. So in second generation, we have IGL, LMA Supreme, PROSEAL LMAs, and in third generation is a complex with the two draining tubes consisting of BASCA mask. Comparing supraglottic airway devices with face mask and tracheal intubation device, advantages with the face mask is that both hands will our hands will be free, as it will be self-retaining, and it provides better seal in bearded person. And disadvantages is that it is more invasive and there is more risk of airway trauma, and it requires skilled personnel. So compared to tracheal intubation, the advantages of supraglottic airway devices are it is less invasive, and it can be used in very difficult tracheal intubations. There will be less tooth and laryngeal trauma, less laryngosspasm and bronchospasm, and does not require as much relaxation as muscle relaxation as it is required in endotracheal intubation. But disadvantages are that it has increased risk of gastrointestinal aspiration, as it cannot provide high pressure cough, and there is less secure airways, and there is a limitation in positive pressure ventilation. So coming to our LMA Classic, so this is a LMA Classic, and it is a very simple device that can be used. So this is the cuff, this is the ventilating end, and this is the airway tube. This is 15 mm universal connector, and this is a pilot balloon to inflate this cuff. Distal end is attached to an elliptical cuff that can be inflated through a pilot tube. Deflated cuff is lubricated and inserted blindly. So this is one of the advantages of LMA, that it can be inserted blindly into the hypopharynx. So once inflated, it forms a low pressure seal around the entrance of larynx and protects the airway. In over 2,500 studies, LMA Classic is undoubtedly the most well-documented device and has been shown to provide effective ventilation in cannot intubate, cannot oxygenate events in 94% of the cases. So why we are studying about LMA Classic or LMA devices is that these devices are very effective in preventing the airway, but due to delay in difficult intubation of endotracheal intubation, difficulty in endotracheal intubation, the choice of LMA Classic or LMA laryngeal max airways is less. So we have to understand that they can be used very effectively in case of failed intubations as well. So this is a procedure of inserting a laryngeal mask airway, Classic, LMA Classic. It consists of this cuff tube, and we have to hold this device in a pen holding fashion between our thumb and index finger, just above the mask. And we have to first check if this tip will fold or not. And in this other side, we have to lubricate it first. And in a pen holding fashion, we blindly insert it against the hard pallet, and we slide it until definite resistance is felt. Uh, this will be the method of inserting laryngeal mask airway. And successful insertion, as all airway devices require, successful insertion needs a choice of appropriate size. The leading end edge of deflated cuff should be wrinkled and free facing and facing away from the aperture. Only back side is lubricated, and the ventilating side is left free. Patient's placement should be in sniffing position or dog barking position, as we say, which is also used in endotracheal intubation, which is basically a flexion of the occiput back of the neck and extension of the chin, uh, which will be called as morning sniffing position. So we use index finger to guide the cough along the hard palate and down into high pharynx until increased resistance is felt. Uh, and we have to inflate the cough with correct amount of air. And we can see in this other table that necessary cough volume and size of the patient, size of the cough we have to use in a patient. So adequate size should be chosen, and uh, adequate inflation of the cough should be done in order to secure the airway. So advantages of LMA Classic are: it is easy and fast. It reduces anesthetic requirement. There is less coughing and sore throat, and it can be done by relatively less skilled personnel. However, the disadvantages are this is a low pressure seal and has increased risk of aspiration, and there is no mechanism for suction, so it is difficult to suction. As we have already said, we have to check the tip first, but if the tip gets folded, it may cause obstruction. Also, if it presses the epiglottis and closes the epiglottis, it also may cause obstruction. And it is an inadequate seal, hence positive pressure ventilation is very difficult, as only up to 30 ml the cuff can be inflated. So above that pressure, we cannot give positive pressure ventilation. So another modification, there are different kinds of modification of this classical LMA. One of them is PROSEAL LMA. So in this modification, as we can see, there are two tubes. So one tube will be for ventilating, whereas another tube will be for drainage. As we can see, one tube is opening into this cuff, proximal end of the cuff, and this draining tube is opening into the distal end of the cuff. So the advantages of this PROSEAL LMA is that we can insert a Riley's tube from here and suction. So gastric aspiration will be less, as we can directly decompress gastric contents from this draining tube. So other advantages of this PROSEAL LMA is that the cuff will be larger, so the seal will be more tighter than a classic LMA. And we also have a draining tube that will decompress the gastric contents, and aspiration risk will be decreased. So as we have already said, advantage will be gastric tube for deflating the abdomen and suction. Dorsal cuff provides better seal, less incidence of gastric aspiration, and disadvantages will be more incidence of trauma, as the cuff size is more and more resistant to insertion, hence takes slightly more time. Similarly, due to larger size of the cuff, and requires greater depth of anesthesia. This is LMA Supreme. It is also another modification of laryngeal mask airway. So in this LMA Supreme, there is a fixation tab. So this fixation tab provides a visual guide to the correct size. So when we insert it, insertion is also similar to that of classic LMA. And this fixation tab lies just in between the lower and upper incisors. So it will provide a better guide towards the incision. After inflation, the fixation tube should be 1.5 to 2 centimeter from upper lip. And airway tube is elliptical, and it provides a better anatomical shape. So it is a curved tube and provides better anatomical guidance towards placement. And there is a drainage tube, so it also provides some benefit against aspiration, as we can do suction through this drainage tube. And the cuff is enlarged and distal part is molded, so there is a risk of folding. So the cuff is more rigid, as well as uh, so it has less risk of folding. So another modification is the LMA Fastrach. So it is also known as intubating LMA, as we can pass ET tube, endotracheal tube, through this LMA. So it is also called intubating LMA, and can be used as a rescue device, as it has, we can see it has airway tube as well as a blind fibroscope for guided insertion. So it can be used as a rescue device in the difficult intubation. So one of the advanced second generation laryngeal max airway is the iGel LMA. So this does not has an inflation cuff. So it is a self-fitting cuff, which is made up of medical grade thermoplastic elastomer known as styrene, ethylene, butadiene, styrene. So it comes with a cover, and in this iGel LMA, the insertion is slightly different. Uh, we take this out from the cover and apply adequate jelly towards the non-ventilating side of the cuff, and we hold it not in this just above the cuff, but towards the proximal part, and insert it against the hard palate. And this is self-inflating cuff, so it has more tighter, more as we proceed towards the area, due to humidification and temperature, it will fit tightly and expand, so it will provide a better seal. So iGel LMA is a superior device, and it also has gastric tubes for decompression, and it will prevent aspiration. As we can see here, this is the epiglottis, and this is the esophagus, this is the trachea. It will be placed like this, and we can easily uh, decompress the stomach by suctioning. So it is very much comparable to endotracheal tubes, in sense that it has low risk of aspiration. So in a study done by Thomas et al., it was found that supraglottic airway devices were used in multiple tracheal intubation attempts. So according to our guideline, after three unsuccessful attempts towards intubation, we should move towards a supraglottic airway device. But it was seen that after multiple tracheal intubation attempts, 10% of the time, supraglottic airway device was used, and in difficult face mask ventilation, 12% of the time supraglottic airway devices was used, and in failed tracheal intubation, 35% of the cases were supraglottic airway devices was used. So what conclusion they came was alarmingly, only 18% of cannot intubate, cannot ventilate cases received SAD, which resulted into next grievous step, or more invasive step, that is surgical procedure, thyroidectomy. So if we use supraglottic airway devices in time, the risk of frontal neck access or thyroidectomy, cricothyroidectomy, the incidence will be much lesser. So another old airway devices are esophageal tracheal COMBIT and King's laryngeal area. So it is an old airway devices. It consists of two tubes, one longer blue coded tube, uh, and another the shorter clear tube. The longer blue tube has occluded distal tube that forces a gas to exit via its side. So as we can see in this picture, this is the longer tube, which is blind in the distal end and has multiple perforators towards the um, and has multiple side perforators, and other tube has a opening in the distal end. So this is the gastric tube and this is the ventilating tube. Combi tube is also inserted blindly into mouth and advanced until two black ring on shaft corresponds to upper and lower incisors. So it has a marking here, and it should be, as we can see here, it has a marking. So it is also inserted blindly, and there are two pilot balloons to inflate distal and proximal cuff. Distal lumen of the combi tube usually comes to lie in esophagus approximately 90% of the time, so that ventilation through the longer tube will be force gas out of the side perforation. As we can see here, these are side perforators, and it will lie just towards the side of the airway, and esophageal tracheal combi tube inserted such that the perforation inside, and it will provide ventilation, and other tube will be for suctioning and gastric suctioning. Shorter tube can be used for gastric decompression. So inflation pressure is around 100 ml for proximal cough and 15 ml for distal cough. So this is a combi tube. Advantages is it can be inserted blindly, and it can provide adequate ventilation and oxygenation with moderate protection against aspiration. Gastric contents can be aspirated through the lumen, and the proximal balloon provides better seal. Disadvantage is it is expensive and increased chances of tracheal and laryngeal injury, as it consists of two cuffs. King laryngeal tube. It is another device that can be used. It consists of a tube with a small esophageal balloon and a larger balloon for placement in hypopharynx. The lungs are inflated from air that exists between two balloons. As we can see, in between the two balloons, there are ventilation holes which acts as a ventilating hole and aids in the passage of air. And a suction portal distal to the esophageal balloon is present, which provides advantages of decompression and decreased risk of aspiration. So the main advantages are that it is less invasive and has more benefit in failed endotracheal intubations. So now we'll proceed towards the advanced airway devices that are laryngoscopes and endotracheal tubes. Laryngoscope. So a laryngoscope is an instrument used to examine larynx and facilitate intubation of trachea. So it consists of two parts, a blade and a handle, and when those two are locked, there's a bulb placed, and the bulb will ignite and show light. Light from fiber optic bundle tends to be more precisely directed and less diffused. And there are two types of blade commonly used: Macintosh and Miller blade. Depending on the design of the blade, they have been named. So Macintosh will be a curved blade, and Miller is a straight blade, as we can see in the figure. So this is a sniffing position with the flexion of the occiput and extension of the chin. So it will keep the airway, our anatomical area in a single line, and help in the procedure of intubation. So we will gently we'll keep the patient in the position, sniffing position, and we'll glide the tongue towards the side and insert insert our blade such that it lies towards the epiglottis, and we'll gently lift with the lifting movement. We will visualize the epiglottis and vocal cords, and care should be taken that the twisting movement of wrist should not be done, as it may injure the lip and teeth. After insertion of laryngoscope, we can see vocal cords and other structures, and this will aid in the insertion of our endotracheal tube. So endotracheal tubes are most commonly made from polyvinyl chloride. The shape and rigidity of tracheal tubes can be altered by inserting a stylet or a bougie. Patient end of the tube is beveled to aid visualization and insertion through the vocal cords. So another very interesting part of endotracheal tubes is Morphy's eye. So in case of obstruction of this beveled end, Morphy's eye acts as a port for ventilation. So complete obstruction will not be there. It is of utmost importance that we choose endotracheal tube of correct size. So this is a formula we can use to determine the diameter of the endotracheal tube. In child, 4 plus age divided by 4 will give the appropriate diameter, and in adults we generally use in female 7 to 7.5 mm internal diameter endotracheal tubes, and in male 7.5 to 9 mm internal diameter. So factors affecting resistance of endotracheal tube: internal diameter. The smaller tube provides higher resistance. Length of the endotracheal tube: more length provides greater resistance. And configuration: average changes in diameter, like kinking or twisting of the tracheal tube, will increase the resistance. So tracheal tube permits cough of tracheal tube permits positive pressure ventilation and reduces the likelihood of aspiration. There are majorly two type of endotracheal tubes: a high pressure low volume and low pressure high volume cough. High pressure is associated with more ischemic damage to tracheal mucosa and are less suitable for long term intubation, whereas low pressure increases the likelihood of sore throat, as it consists of high volume, and it increases the likelihood of aspiration, spontaneous extubation, and it is a difficult insertion. Factors affecting cough pressure. So the tight seal that is formed by the cough of endotracheal tube depends upon inflation volume, diameter of the cough in trachea, tracheal and cough compliance, and intrathoracic pressure. Complications, as we have already discussed, during endotracheal intubation, use of laryngoscope may lead to mechanical trauma of the teeth, tongue, palate, pharynx, and larynx during intubation. Prolonged intubation may cause necrosis of laryngeal structures, leading to need of potential tracheostomy. So this is a guideline given by Difficult Airway Society, DAS, difficult intubation guideline. So it consists of plan A, B, C, and D. In plan A, we first try laryngoscopy, in which in emergency cases, 3 attempts should be given, and 1 should be given by most skilled person available at the setting. After 3 failed intubation, we have to go for plan B, which is supraglottic airway device insertion. So this can be life-saving for the patient. Supraglottic airway device. So in cases of failed supraglottic intubation, we have to stop and think, wake the patient up, intubate trachea via SAD, supraglottic airway device, proceed without intubating the trachea, or we have to go for tracheostomy if there is failed supraglottic airway device. Plan C is face mask ventilation, and if we cannot intubate and cannot oxygenate, we have to go for surgical procedure, cricothyroidectomy. This is all from my side. Thank you.